Okay, hello everyone. This is we're going to present this case. This is a 75 years old man with history of dyslipidemia, former smoker, and as you can see in 2011, stable angina with this in the proximal LED, and now this year in the 2023, stable angina, but with bad functional class 2-3 on optimal medical treatment, preserved ejection fraction, and as you can see, anterior hypokinesia on the echo. In the ECG and the lab, there is no significant findings. And you will see the angio. We have the right coronary artery with not lesions, occlusion in the circumflex, and we can see two lesions, one distal in the LED and another one in the proximal first diagonal branch. So this is the plan and the procedure. We have distal in stem restenosis, and also we have a bifurcation, in this case LED to first diagonal branch, a side branch lesions. So the plan is to do imaging guided PCI, possible Plaque modification technique according to the result of the OCT. We have to discuss the technique on bifurcation. And now I give the word to Alfonso.
So you can see from distal in this new Ultron software, the distal is in the right part of the screen, and we are going from distal to proximal. This is the distal edge of the stent. You can see severe neoatherosclerosis there, just in the edge. I think at the edge of the previous stent. Mm-hmm. The distal reference diameter probably is near the measurement that Santi has done is near 2.5, 2.3 the lumen. And inside the stent, I think it's pretty okay. And the problems come again at the proximal LED. This is the stent, the other wire in the diagonal, and this is the proximal plaque that in the angiography was moderate to severe, but here in the OCT, it's a lipidic plaque with a luminal area under 3 or near 3. So here we have been discussing and probably we need to treat it. And we can show the OCT from the diagonal, 2.4, 2 point something, 2.5. And then you are going to see the severe lesion here. It's occlusive. And when we come back to the LAD, I don't know if we have. This is the just in the ostium, just in the ostium. Okay, so we're going to treat firstly distal LAD, right?
Yeah.
So please give us a NC balloon 2.5. We have been discussing if it was a good case for doing laser, that we are an expert center in this technique, but probably after OCT results is enough with the plain balloon dilatation. We'll see.
Sí.
So there is no, Dr. Jiménez Valero is reviewing all the images of the OCT with detail, and there is no severe calcification at any point, nor in the diagonal, nor in the LAD. Not severe. Yeah, the lesions had some spots of calcification, but it's not more than 180 degrees. No deep calcification, no long calcification, no nodules, as far as we see. So we're going to treat. This is the order: distal LAD, then diagonal, probably with drug-eluting balloon, if you agree, and then the proximal vessel. Okay. So give me a test, please. Test, Sophie. I think we are there. Okay, this is a 2.5 NC balloon, just at the edge of the previous stent. 12. 16. Okay. Good expansion, in my opinion. I'm going to retrieve a little bit and confirm the expansion in another projection, okay? Let's inflate here, go up, 18.
This is a non-compliant balloon. 18.
I think this is a good expansion in 2 projections. So probably it's enough with the Plaque modification. Okay, I think to dilate the proximal LAD, Santi, we need a 3.0 balloon, or because probably with this balloon, we are going to do
Yeah.
nothing to this vessel. So I'm going to retrieve it.
Can we use this balloon to delay
The diagonal.
the
later on.
diagonal?
Okay.
Sí.
No, but we are going to. Vamos a tratar primero la DEA distal con un stent, ¿vale? So in stent restenosis is at the edge of the previous stent. We are going to treat it with another stent, a drug-eluting stent. This is a stent implanted in 2010.
Stent
We are going for a stent
2.518.
2.518, as Dr. Galete said, because it's not only the severe plaque at the edge of the stent, just in the mid-distal part of the stent, there is some neutral sclerosis. So we are going to try to cover all the plaque.
18. Sí, vale.
20
sí,
es ok.
eso es ok. Sí, ese está bien, ese está bien.
Vale.
Yes, Dr. Jiménez Valero said that the long lesion is 12 millimeters, but this is a little more longer stent. Synergy from Boston Scientific, 2.520.
The Synergy XD, and we are going to try to land in the more healthy area. So the lesion is only 12. We are going to use a 20 millimeters stent. I think this is the point.
Okay. Nominal pressure is 12.
Go to 12 and then I retrieve a little bit and go up. No?
Okay.
We are going to 12 to nominal
12
pressure.
atmospheres.
This is good expansion here. Go down, and I'm going to retrieve a little bit just to inflate high atmosphere just inside the stent and not in the distal here. Okay, good result. So we are going for the diagonal. These type of bifurcations are tricky always for us when the side branch is the only vessel damage. And I said that is the only vessel damage because the lesion in the proximal LED, I think, is far from this point. Probably we can try to fix the diagonal with a drug-eluting and put a proximal stent at the proximal part of the LED. So let's dilate the diagonal with a 2.5 balloon. Let's see. We are going to pre-dilate as always prior to the drug-eluting balloon with a 1-1 NC balloon. The first one, the same one we used for the distal LED. So I am advancing the 2.5 NC balloon, previously inflated, towards the diagonal. We need to dilate slowly here. And if not, we can use a cutting or a grip balloon.
Yeah.
Very slow, only 2.
4 atmospheres.
No, go down,
No?
go down. I'm going to enter a little bit into the LED.
Okay.
Test, please.
Pero no mucho, porque si no.
No mucho. Just there. Okay, 2. Venga.
2 atmospheres.
4.
4.
La tenemos, venga. 6.
6.
18, ¿vale?
16, okay.
Okay, it's a bubble, but I think the expansion is quite good. Now we are discussing here, sorry, in Spanish, that the distances, because we would like not to jail the side branch after using the drug-eluting balloon, and we are thinking if we have enough space to put a proximal stent in the LED without jailing it. So let's go for the drug-eluting balloon. Let's see the result after the drug-eluting balloon that could maintain our strategy or change it. Depends of the dissection and the flow after dilating with it. Yo creo que, ¿cómo lo veis? Yo creo que está bien, es que menos no
Sí,
cogemos
sí.
el... Venga, dale.
Déjame ver la carátula, si puede ser.
Yo creo que 6 casi seguro, ¿eh? Okay.
8.
1 minute. Okay.
8.
So we have 4. Vale. We're going to wait with the inflated balloon near 1 minute. So while we are waiting the inflation of the drug-eluting, Dr. Jiménez Valero is showing us the diameters of the proximal LED and probably is for a 3.5 drug-eluting stent. Okay, go down. Yeah, there's a good result in our opinion of the drug-eluting balloon. It's a slight dissection, no severe, flow is okay, TME3. So I think we can leave the diagonal like that, just in case after treating the proximal LAD we have to do something else. But we're going to, after the results of the OCT that has a couple of spots of calcium there, we're going to predilate with a 3O balloon, and then check everything, trying to implant at 3.5, a short 3.5 stent, probably near 12, 13 from the LAD ostium, just proximally to the ostium of the diagonal. The drug-eluting balloon we used was a Magic Touch, a sirolimus eluting balloon sirolimus eluting balloon.
Déjame la carátula de esto.
We are dilating with an Emerge NC balloon. I think it's the best one. No? Okay, it's about
18.
But the expansion is good. As you have seen, the patient has also a coronary occlusion in a branch of the circ that is a small vessel that we are going to treat today. We're going to use an Orsiro stent, 3.513. It's a ultra thin strut stent, not in the 3.5 diameter, but thin strut stent, sirolimus eluting stent. So probably we can put a stent in this projection and then go to the caudal to confirm. A lot of movement.
Yes, I think so. It's okay, no?
Test, please, because the patient is moving. Okay, implanted. Rápido.
12.
Okay. So I think we can check with OCT, no? Put some nitroglycerin, do the angio, and then, or using the OCT angio just to save contrast. Any questions, Silvio?
Yes, we have one question from Julio Garcia. He's saying that I saw laser ELCA in your plan. Why you didn't use it? Why we changed the plan?
Yeah, we would love to show the ELCA in this case, and we thought at the beginning that it was a good candidate because it was an stent restenosis, a stent implanted in 2010, but this is real life. We did intracoronary imaging, OCT, and in the OCT we didn't see severely calcified lesion, severe neothromosclerosis or calcified neothromosclerosis. So we thought that just with dilatation with an NC balloon or a cutting balloon would be enough, and we succeed. So this is the thing. We prepared everything just to in complex PCI, as this is not complex, but we prepare everything just in case. But now I think that the patient is the most important thing, and with dilatation with balloon was enough. We are going to advance the OCT catheter again to check the distal, all the LAD, the distal and proximal stents. This is the distal edge of the stent. Well opposed, no dissection. 2 layers of stent here. And now there is only one. This is the non-intimal hyperplasia of the previous stent with no severe stenosis. We can see in the longitudinal view clearly the gap between the previous stent and the. This is the osteo of the diagonal. You can see here some dissections with the other wire, but it's open and the flow is okay. And we are entering here in the proximal stent, well opposed here, well expanded. And this is the proximal part. Probably we should post-dilate it. Santi, what do you think? ¿Y cuánto es el diámetro ahí, por favor, Santi? We are discussing because the 4 point something. I think 4. A 4.0 balloon could be okay.
Yes.
Nos dais un balón NC de 4.8. We were discussing because to cover the lesion of the LAD, the stent is just at the bifurcation with the circ, as you can see in the OCT, and at that point the vessel is bigger, and we need to do post dilate, probably with a 4.0 balloon.
¿Cuánto se ha metido en el tronco? ¿1 milímetro o menos?
It's just the ostium of the circuit is what my idea. There is no stem at the left main, so the position is perfect. But at the ostial LED, the diameter is bigger.
Yeah.
So I'm going to put the caudal right. Sube. No te muevas ahora, por favor. Muy importante. No hables ahora, no te muevas.
12, 4.0.
No veo nada.
In this case,
Venga,
12,
2, pero vas a 2, vale.
6, 8, 10, 12, 5 seconds.
Perfecto.
Go down.
We're going to finish with a new OCT pullback to check the post-dilatation. Contrast is fine. The patient has no renal dysfunction, so we can do it. I think it's enough to see the proximal part, no?
Yes, see,
From
distal to
here.
the diagonal.
Give me a test, please, just to check the guiding is inside.
Dale un test.
That's normal. Let's go into check the OCT. I think it's a functional PCI. Probably if we would like to improve the aesthetic of the diagonal, the LED would have needed more stents, more metal there, but I think we should optimize our PCIs with imaging. So let's check. And I think if the OCT is okay, we have finished. This is the ostium of the diagonal with the wire as a marker, the distal part of the stent that was okay before, and the proximal part is slightly better.
Yeah,
the proximal part just in the origin of the circ probably is 4.5 or 4.8. I think it's enough.
Yes.
There are some frames malapposed at the proximal part that we know that the outcomes are not as bad as the distal malapposition. The expansion is fine, and the thing is that we will need probably a very big and small balloon to oppose this part, and I think it's better to leave like that.
Yes, it's only 1 millimeter inside the left main. It's only 1 millimeter. It's only 1 millimeter. Is not important.
I'm going to show you the last angio here. Probably we can do the last angio in the caudal and finish. Okay. Yes, look, this is the LED ostium that before this post-dilatation was some malapposed stress, and now is quite better.
But no, in the
in the origin of the circ,
it's not possible because
this is the image we have seen before. No, it's a very good result in our opinion. So test please para ver que estamos dentro. Okay, let's do the cine here. Cine. Very good. For another midstream case, we can discuss this circ and this CTO. Okay. Okay, finish. Okay, so thank you to all the people here, to our nurses, our team, people in the backstage helping us, and also to Midstream for having us. And we will see you next week with more cases from La Paz University Hospital. Bye-bye.
Thank you very much.